So good morning again and welcome. My name is Angie McRae. I'm the Child and Family Engagement Manager here at the Mental Health Association of Maryland. Today's session is being recorded and will be made available to you this week. Our speaker today is Dr. Aja Goodwin, and she'll be presenting Understanding and Supporting Minoritized Youth in the Digital Era. Minoritized youth in the United States experience various structural, institutional, familial, and individual stressors that may increase their risk of mental health concerns. The consequences of unmet mental health needs for minoritized youth may include academic difficulties, social concerns, increasing rates of suicide, and other detrimental long-term outcomes. This presentation explores the help-seeking continuum from problem recognition to help seeking, highlighting cultural, contextual, and technological influences in adolescent mental health services and supports. The session also examines diverse sources of support, including digital technology, families, schools, peers, and formal systems. In all, this training aims to enhance mental health accessibility for minoritized youth in the digital era. Give you a little bit of background on Dr. Goodwin. She's an assistant professor at the National Center for School Mental Health at the University of Maryland School of Medicine and a licensed psychologist providing culturally responsive, evidence-based therapy to youth in Baltimore City and surrounding areas. Her research focuses on improving mental health access and help seeking among Black adolescents with internalizing symptoms, including through digital platforms and advancing culturally responsive mental health practices in school and clinical settings. Dr. Goodwin, I'll turn it over to you.
Thank you so much. Good morning, everyone. I'm happy to be here. And thank you for that introduction. We will get right into it so that way we have enough time to go over everything. Our three objectives for today are to build awareness of the mental health needs and help-seeking experiences of minoritized youth, identify barriers and facilitators that influence how minoritized youth recognize their concerns and seek mental health support, and then apply culturally responsive and digitally informed strategies to support minoritized youth, centering youth voice, choice, and real world help-seeking patterns. I will have some points of engagement and ask you all some questions about what you're seeing in the work that you do. So please feel free to share when those points come up in the chat or out loud, as well as share any questions or thoughts that you have as the presentation goes along. It's really helpful for me as I'm doing these presentations to kind of know what this looks like for you all. So please feel free to share all of those experiences as well. We will get started with the national trends in minoritized youth mental health. This data comes from the ACOMA project, which focuses on mental health trends for minoritized youth specifically. It has a lot of information related to anxiety, depression, racial trauma, social media use, and all of those different areas of mental health that are impacting minoritized youth. It looks at intersectionality between race and gender identity and sexual identity. And so at the end, I'll add that resource in the chat if anybody wants to have more information about what this looks like. But this is kind of like some touch points from that data. Um, Overall, minoritized youth are experiencing heightened rates of mental health concerns, especially our internalizing concerns, anxiety, depression, suicide rates. Um, 3 years ago, when the Oklahoma Project did the 2022 data, it was actually 50% of minoritized youth were endorsing moderate to severe anxiety concerns. Now it's up to 60% of the youth that they asked endorsing moderate to severe anxiety concerns. And then you can see in the chart that those concerns kind of vary a little bit depending on racial background, especially with Latina youth, Black youth, and Arab youth endorsing significant rates of anxiety. They also ask about specific symptoms that come up the most within those youth, and the youth endorse feeling anxious, worried, putting off making decisions, seeking reassurance, moments of sudden fear and terror, and it kind of separates like which symptoms are heightened the most across these different minoritized racial backgrounds. Similarly, when we're looking at the intersectionality between race and gender identity, Latina boys and men are more likely to report moderate to severe anxiety concerns, and then 84% of Black non-binary genderqueer youth and young adults report moderate to severe anxiety. And then you kind of see how it ranges across the different intersectionalities with girls and boys with girls and boys and gender diverse youth across the different minoritized racial groups. Similarly, heightened rates of depression as well, with 60% of youth endorsing moderate to severe depression, including feeling down, little interest or pleasure in doing things, feeling tired or having little energy. And then you can kind of see what those rates look like across those racially minoritized youth as well. Um, for depression, Latina girls and women report the highest percentage of moderate to severe depression at 72%. And then among non-binary, genderqueer youth and young adults, 95.4%. So almost everybody who was Black and non-binary or genderqueer endorsed moderate to severe depression concerns. And so we have all of these different data points that these youth across these minoritized identities are struggling with their mental health at varying rates. For our non-suicidal self-injury, Latina youth and young adults have significantly higher reports of non-suicidal self-injury, so cutting without or intentionally hurting yourself without the intention to die. While the suicide rates among Black youth are rising increasingly compared to all of the suicide rates across other minoritized youth or other racial groups in general. So the suicide rates are increasing among Black youth 144% within Black youth ages 10 to 17. So we have lots of mental health concerns that are increasingly rising and different reasons that that is coming up. But even with those differing, even with those heightened mental health concerns, there's differing access to mental health treatment. So youth who are not accessing 50 to 75% of minoritized youth and families do not have access to traditional formal mental health supports. That's what we think about with our therapy, our outpatient services, primary care. However, youth who are accessing formal services are still doing something to support their mental health. So, what does that look like? 95 to 97% of minoritized youth use social media. The average age of social media use is 13 years of age. As we know, social media has its pros and it has its cons, and so not all of these youth are using it in a positive way. But positively, minoritized youth use social media to help create safe spaces, especially in the face of these mental health concerns, help to get shared stories, help to find information, especially if there are other like familial or structural barriers to getting information about mental health support, as something as simple as, do I have anxiety? What does anxiety look like? What does depression look like? So they are turning to these social media spaces for mental health support. And this is as evidence. These are sources of prior and current mental health support for Black adolescents specifically. So I asked about 400 Black adolescents with severe or significant stress, anxiety, and depression symptoms. Where do you currently go or have you gone in the past to seek mental health support in the face of a personal or emotional concern? And as you see, um, most of the youth are going to internet searches or health websites. After that, social media pages and videos. After that, online mental health assessments, interventions, mental health apps, and then we kind of skip to those informal social supports, friends, parents, caregivers, um, school mental health professionals and online forums, and then doctors, outpatient, and then some of our other like community-based agencies or our phone lines and our helplines and our text lines. And so traditionally, when we measure access to mental health support, we look at this: how many people are going to doctors, how many people are going to outpatient professionals. But there is evidence that when these youth are facing these mental health concerns, it's not that they're doing nothing, they're going elsewhere. So, how can we make these other spaces either more supportive or more evidence based, or highlight them in a way that meets the needs of these youth, especially with these drastically rising mental health concerns? Okay. Now we are going to talk about barriers and facilitators to mental health help seeking, and this can be in various of spaces. These barriers and facilitators can come up to non-traditional care, informal care, traditional care. And so I'm going to start by showing a video from the voices of youth. And I do just want you to kind of like pay attention to what you hear, pay attention to what stands out, because I will be asking questions about what is showing up for you in this video and kind of how it relates to the things that you see in your work. Give me 1 second while I find the video.
Taking that first step is kind of scary. Like sitting in that chair, speaking to someone. It was really hard. I'm not someone who tells people things easily. It took me about a month to actually do it. For my initial thought of getting help, it took me about a month to fully convince myself. And in the end, I didn't even seek out help. I asked my friend if she could tell the social worker. I was waking up throughout the night a lot and I couldn't sleep. And I would wake up out of breath. I couldn't breathe. I was very disoriented. My family and I had thought like it was part of my asthma because I'm asthmatic. Um, so we went to the doctor, and the doctor told us that it was panic attacks. He diagnosed me with general anxiety and depression. He gave me medication that would help me. Once we got home, like my dad like completely got rid of all the medication. I remember him going on a whole like speech for like about an hour saying how I shouldn't be that weak and that I should be stronger and I shouldn't complain about things. My parents both grew up in difficult situations in their country. Their mentality was what they went through, they came out fine. They didn't have to talk to anyone. So why should I have to talk to anyone? I don't think mental health is talked about in the Latino community because we're kind of looked at as like strong and macho. So it's just like, if you have this issue, it's just, you're just kind of looked at as weak or there's something wrong with you, It's just, it's never been an option to go to a therapist. It's deemed as feminine if you speak about like feeling sad or anything. So most families are like, most cultures don't want to hear about it.
One of the other barriers to Latino families seeking out mental health services is that in the Latino communities, there might be a sense of machismo and pride that we can handle our own problems. I think that sometimes in the Latino communities, they're more likely to resort to alternative rituals or healers for mental health guidance as opposed to seeking out social workers or psychologists to get help.
It's because of lack of education. They don't have enough information. They don't know different types of mental illnesses that are out there. For example, if someone is depressed, that's a mental illness up to a certain point. They don't consider it that. No, you have to man up. No, you have to be strong. Forget about it. That's in the past, blah, blah, blah. And what they don't realize is that every individual responds to things differently.
I've definitely gotten better through speaking to someone. Before, I was a really quiet person. I was really shy. I was really anxious. Like, I couldn't speak to people because I'd freak out about it. My personality, I had a complete 180. Like, you would not recognize the person before I was seeking out help and then the person I am now. And it really helped me, I guess, grow into myself and realize that, you know, it's kind of more than just a sadness or a worry.
Okay. Anything stand out while I bring my slides back up to ask you all specific questions? Anything that you notice, anything that stands out, and you could put it in the chat or come off mute.
Hi, everyone. I think one thing that stood out to me was the fear and stigma that's still around seeking mental health services. There's so many resources, so many information out there, and it just stood out to me that, there's still that stigma
Taking
among
that first step.
the population regarding accessing mental health services.
Yes, thank you for sharing that. I see someone else put in the chat, don't seek help until they experience somatic symptoms, more comfortable with seeking help for physical health, lack of support from parents, stigma against mental health challenges. Perfect. You guys are experts. Anything else that stands out? And specifically, I have my slide pulled up.
I
In the
just like
chat. Oh, go
I'm
ahead.
sorry. I just like to add that the historical trauma that their parents have experienced impacts how they view resilience. And that really resonated with me. I think that happens in a lot of cultures.
Yes. Yes. So historically, what has been either allowed or what has been positioned as the way that we handle the problems is how I teach my children or the people that come after me to handle those problems. And not even realizing that there might be a disconnect in that within the current age. Thank you for that. We have a list of barriers on this page that we will talk about. These barriers come up across lots of different youth, but they're very much more heightened in minoritized youth when we're thinking about problem recognition or mental health literacy, stigma, and this could be stigma within myself, stigma within my family, my culture, things that I hear about mental health that contribute to stigma, immigration and acculturative stress. So how do I view mental health compared to where I was born, if I wasn't born here? And then kind of like Terry said, those historical differences and the ways that we navigate those discussions about mental health or how we handle these problems, prior negative experiences with mental health care, views of treatment effectiveness, cultural or language mismatch. Do I have somebody that looks like me? Do I have somebody that speaks the language that I need to be able to fully understand what you're trying to teach me or tell me? Fear of negative consequences, lack of confidentiality, self-reliance, lots of historical mistrust of systems, people, mental health care, affordability, availability, accessibility, parental barriers, lack of social support. So anything that stands out from that video that we haven't covered, I'll go over a few in the next few slides as well. Okay. But one of the barriers that came up in the video for me that I wanted to highlight as a barrier for help seeking for minoritized youth is problem recognition. So mental health literacy, problem recognition, kind of all tied into the same inability to identify a mental health problem. Varying presentation for minoritized youth, what a mental problem is, more likely to show up or pay attention when those somatic symptoms come up, those panic attacks, my stomach hurt, my head hurts. I think it's a health problem. I think it's asthma, but it's really, a somatic symptom of a mental health concern. Or irritability and anger. So some of these mental health disorders get misdiagnosed as behavioral concerns when they might be anxiety or trauma-based or depression. And so all of these things play a role in problem recognition, from the way that we recognize problems as mental health professionals or school staff or wherever we are working, to how parents understand these problems. And the better that we can understand the problems, the better that we can communicate it to the families. So if we're identifying it incorrectly from the beginning and we're telling a family that, hey, this might be ODD, but we didn't really anticipate or assess for the varying presentation that might come up, and we're telling the parent that it's a behavioral concern, and so they're taught to miss the other internalizing symptoms, then we're kind of setting people up for failure when it comes to those problem recognition and mental health literacy within our systems as well. And then youth are increasingly learning about mental health from peers in digital spaces, especially the Gen Z era. They have learned that if I have a mental health problem, I don't just want to always sit and think about it. Maybe I'll go into these shared spaces. I hear them talking about it to their friends more. When I was in the school as a school mental health program clinician, it used to be that I had to like pull people in secret. And now they're like, oh, there's my therapist. Hey, like, so it creates a little bit more of this openness about like problem recognition and mental health literacy, which has its pros and cons. Personal views of self-reliance and resilience, which again comes from the messaging or the historical components. You don't just develop self-reliance or resilience just because, but it does come up as a barrier that some minoritized youth prefer to deal with their own mental health problems, feeling emotionally closed off and having difficulty trusting others with their struggles, fear of judgment or criticism, especially if they shared a problem. Hey, I think this is what's going on. And I go to this person and then they either meet it with judgment or they laugh it off or they criticize it or they say, that's not how we handle these problems. Then 9 times out of 10, the next time you are more likely to just kind of say, okay, I'll deal with this on my own. So those personal views of self-reliance and resilience come up as well. Also in the video, those messaging of public stigma, family and friends and peers often use stigmatizing language about mental health, that you're crazy or you're weak. We don't need medications to handle this problem. This is not how we do things. Avoiding mental health conversations, minimizing youth needs for mental health support, even down to the fact that the family was even open in front of the doctors or wherever they went to say, like, yes, we'll start our child on this medication or we'll get them the support for therapy or whatever the case may be, and said all of that to the doctor and then went home and then threw all the medication in the trash and told their daughter that this is not how we handle these problems. And so even if we don't see it on the clinical side, families are presenting these barriers to their youth, sometimes behind closed doors, and we don't even know that. So caregivers prefer youth only seek help within those trusted networks. And then sometimes we don't even know we're creating public stigma because maybe my mom is having a conversation with her sister in the kitchen, and they were talking about something completely unrelated to me about mental health with somebody else's family or another family member or something that they saw on TV, but the messaging around it is very negative. So then I'm assumed that my mom and my aunt don't really believe in mental health because the last time I heard them have a conversation, it wasn't positive, it wasn't helpful, it wasn't productive, it was very negative. So then if I'm having a problem, then I probably can't go to those people with those concerns. Similarly, that cultural stigma, those cultural messages are often framed mental health as invalid, unimportant, or a sign of weakness. Be strong and toughen up messages. And then youth struggles were minimized due to perceived privilege, depending on where, if their family was born somewhere else and they immigrated over here, so perceived privilege to in comparison to family or other people that are in the country that they immigrated from, or comparison to other generations in the past. This is how hard I had it when I was your age. You have it so much easier than me. You shouldn't have these mental health problems because you have this nice thing or this car, or this iPad, or these things. And so I just believe that you shouldn't have mental health concerns if all of these things are better than how it used to be or how other people have it. So those all play a role in those cultural stigma messaging for minoritized youth as well. And then religious views often reduce mental health, and generational views who say, go pray about it. This is how we handle mental health concerns. Go read the Bible, whatever kind of religious views of how mental health should be handled can also create a cultural barrier for help seeking as well. Okay, have another video.
I wish I had more support from my parents, especially my mom. She's an immigrant. She came here when she was, I think, 9 years old from Jamaica. And so to her, mental health for a very long time didn't exist to her until she saw how it like affected me so detrimentally. And she realized like, oh, this is real. You're not just making this up. Like this is a real thing. And so I just wish that my parents were more supportive. I mean, she is now that she realizes the effects of different things, but I just, yeah.
Definitely 100% agree because my like the exact same thing. Like my mom immigrated here like in 2007 when I was born to have me, and it wasn't until I would say like freshman year when she got a call from school that she was like, "Oh, like this is real. Like you need help." And just that whole journey, even like 2 years later when I ended up being in treatment, she was just like, "Oh, like, is this really what you need?" And it's like everyone is like questioning her, like, this is what like your child needs. And it's just like that difference, um, like that my mom had in her childhood and her relationship with mental health really played a role in how she treated mental health towards me. And it wasn't until, like you said, like once my mom realized how detrimental it affected me, that's when she started to take it more seriously. And also in schools, when I attended the Black Youth Suicide Prevention Policy Academy in Maryland over the summer, uh, they had a student panel, and someone mentioned that like they wished that people wouldn't be so quick to send like a child to the hospital like when they say that they're suicidal. Like I understand that like yes, like that's something very serious, but there's also like passive thoughts. Like not all thoughts are active. So I wish that like more faculty in schools would take the approach of like actually like sitting down with the student, like talking them
So
through
like more
whatever's
mental
going
health
on.
training.
Exactly, rather than just like straight like sending you to the hospital or calling your parents because that's not helpful for anyone.
They're not good at processing with I think a lot of schools are their system of processing mental health issues with students is terrible.
No, yeah, I totally agree with both of you guys. I think it makes an even bigger disconnect. Because that's how the process is, and it makes kids scared to go to anybody for help because even sometimes friends, like I've known, or I know that I have had to go to a teacher because I was worried about one of my friends, and like I didn't know what was going to happen after that, but it's so scary to like not know if like they're gonna be sent off right away, if they're gonna get like a talking to, or if it's just not gonna come up to anything. It's really, yeah.
I think what really scares me the most is not more about the friends or like the teachers aspect, because I do understand teachers are mandated reporters and they must report something if they see or hear something. However, to me, it's more of the hospital aspect because the stigma surrounding mental hospitals and asylums, I just kind of feel like in the United States is not something that I would want my child or my friend or even me personally to go to if if from what I'm hearing from the internet, all those and all from all sources that the hospital is not really treating you; it's just containing you.
Yeah.
So
I've had situations where I think I've been to mental health hospitals 5 times in my life, and I've had to stay for like weeks on end. It's really not what people think it is. Like, it's not like, oh, you just go to the mental hospital and you get better and you come out and everything's yeah, no, and considering the fact that I've been back so many times, like that goes to show that it's not this like easy fix that like teachers think that it is to just send kids off to a mental hospital.
That's so true.
Like, you get what I'm saying? It's not just like,
Yeah, and even like the same thing with like treatment facilities. It's like they're really just there to like kind of fix you on the outside, and they don't actually address like what the root causes are. So I feel like overall, like the way us as a society treat mental health, both like in and outside of like the hospital, treatment facilities, whatever it may be, whether it's in schools, at home, whatever, like we just treat mental health so poorly and nothing is getting
it's so
fixed.
short term. It's very like thinking, oh, okay, how is this person gonna feel or be doing in like a month? Instead of like, this is something like when people get diagnosed with certain mental illnesses, some of them are lifelong. Like me personally, I've had ADHD, anxiety, and depression for a very long time since I was probably like 6. I think depression was more when I was like 12. I got diagnosed with that, but I think people don't understand that those things don't go away. Like, it's something that I'm gonna have to deal with and figure out different strategies and ways to cope.
Especially if like you're misdiagnosed or undiagnosed, like there's no way of getting help because you don't know what type of help you need, and it's so difficult for everybody to go.
To say more about that, that's exactly why I kind of feel like we need people that have gone through um those types of perspectives and roles to be in the education, in the healthcare, and just to facilitate the process of like, okay, like I understand where you're coming from. I hear you. I see you.
To
Like,
relate, because a lot of these teachers can't relate to some,
Yeah.
especially the white teachers. Like when I am talking to them about like anything racial, and they try and come in with that, oh yeah, that like white sympathy, just like it's almost irritating.
And it's so hard too because they just grew up so different from us. And then it's also like the different generations, like they have learned so much different than like what we're learning and like social media and like phones and all this extra stuff. It's like it's so new and like we don't know how to navigate it, even though we think that we do.
And because they haven't gone through it, you just get seen as like damaged goods, which brings us back to just getting sent off like as soon as something comes up.
Okay. What comes up in that one? And all of those youth in that video identify as Black. So what comes up in that round table talk, we could call it, among those Black youth? Which barriers come up? And you can put it in a chat or share out loud. And it's some of the same barriers, but I show those two videos because those youth touch on some other very important barriers as well. So what comes up in that video?
I think there is a tension between medicalization, how the care itself is provided in terms of just the medical model of providing care, mental health services, because it just made me remember a particular project we worked on I'm in Texas, so something similar where we had to deal with families, where we were speaking with families and just knowing when to provide services within the school system. So we're looking at level issues where we're saying, should we have, is just having a nurse, for example, sufficient? And the nurse provides just physical care, not mental health services, or the counselor in the school, how can they be that first point of call where they provide that therapy, like even if it's a talk therapy, before now transitioning to care. So I think the idea that based off on the conversation that they have to just, oh, I have this issue, and then boom, you're taking them to the mental health facility. It's like, hey, I don't think I'm there yet. Like, let's do baby step and let's talk first. So I think there is that issue of resources, issue of the tension as to what's the model of care, how should it be handled, what's the level of severity that should make the youth to be transferred to a hospital, and things like that. At that, I think the care pathway needs to be
Yes.
really looked into.
Yes. Thank you for that. And so the care pathway, I'm in a school, I say that I have a mental health concern, and then I'm automatically transferred to the highest level of care. When there should be some steps in between, especially if that significant jump from here to here is kind of going to make me not want to share again, because I really didn't think that it was a big deal. And I understand that you're a mandated reporter, but I came to you to help me, not to ship me off to another facility, or not to go, overreact in this crisis and then send me somewhere that I don't even think is helpful anyway, because I've been sent there 5 times and it doesn't actually help. So what can we do differently?
So that begs the question, what is the referral pathway? What does, what triggers um,
Yeah.
therapy? What
Mhm.
triggers hospitalization?
Right.
I guess that's for mental health providers and the school system. That would be a good thing to figure out. I
Right.
guess that should be a good thing that for you to that should be a next project for you.
Yeah, I mean, and I think it just varies across the schools and the resources that they had. You already touched on this. So if you don't have a mental health professional in the school to be able to do a thorough risk assessment to kind of say, I don't think that this should escalate to this level, then, they're doing what they can with the resources that they have. School policies have different levels of risk that they're willing to take on or not willing to take on when addressing those problems. But just balancing that, like, I know that school systems have to do what they need to do. Even one of the kids said, I understand that teachers are mandated reporters. I know that all of these systems exist, and what can we do to be more mindful about creating a more supportive, holistic um, system that meets youth where they are and doesn't add to the mistrust and the lack of understanding and the fear of the negative consequences that these youth are already navigating. Thank you. Um, Also, again, like parent-child disagreements and the need for help, those generational differences in views and acceptances of mental health treatment. Specifically, some research says that caregivers, specifically of Black and Asian youth, are unaware of their teens' mental health concerns in up to 80% of cases. And this is especially for kids with anxiety, depression, those internalizing type of concerns. And so there's already a significant gap in what caregivers know, which is pretty problematic given that parents are usually the primary initiators or the primary consenters of help seeking. And so, if most of the parents or caregivers don't understand that there's a problem, don't know it's a problem, I know it's a problem, but I don't agree to actually solve it this way, then that creates even more of a need or a gap. And youth wanting to get mental health support, but they can't because they kind of have this gatekeeper that's keeping them from being able to seek support. However, there are 31 states across the United States that allow adolescents younger than the age of 18 to consent to their own mental health treatment. Maryland's age of consent is the lowest. It has pros and it has cons. And I've seen it used in a um, differences of ways. I would say in our hospital, we usually use the 16 age, which was the age of consent as of like 5 or 6 years ago, before it switched to 12. But we do allow for some youth to be able to say, hey, this is what I want to do. And they can start therapy in some spaces without parent consent, but they can't take medication and so on and so forth. So we are trying to be creative about these spaces. We still want to involve parents, but we don't want parents to be the barrier. And so having to balance those two things, knowing that we do have some policies and procedures that allow for nuances, if we are stuck with that parental barrier. negative experiences of mental health care, challenges with finding the right medication, the lack of follow-up with therapists, mental health professionals not responding to their needs in time. I don't even know your timeline for getting back to me. I called you and you said that you would get back to me, but I don't know if it's a week, 2 weeks, a month, 3 months. Inability to connect to therapists due to their background or dismissiveness and invalidation, and then just therapist negative attitude, lack of care or approach, and just those disagreements between what care should actually look like all create very negative experiences with mental health care. And it could be down to a very small touch point. So, like, I find that youth, even in schools, they don't know the difference between a school counselor, a school social worker, a school psychologist, a psychologist. They don't know the difference. So they just feel like if I go to this one person and I have a negative experience with that person, then I'm going to deem that everybody within that space is going to give me a very negative experience. So just having to be mindful of those resources, how we're meeting youth, how we're explaining things to them, because we see in both of these videos that the youth have at least a decent amount of knowledge or understanding, and they are open to learning and open to understanding. So we just have to kind of meet them where they are. And then the last barrier that we'll talk about is the provider mistrust. So lack of trust of all of the systems. And this is very historical for a lot of minoritized youth, including Black youth in the United States and families, where there's mistrust of doctors, mistrust of health systems, mistrust of schools, a lot of different historical trauma that contributes to those levels of mistrust. And while we may not see it as our job to fix trauma or mistrust that we didn't create, it is our job to kind of be aware of it, to acknowledge it, to know that it is happening. And so that way we can, address it head on and navigate it the way that we can by building very intentional trust with minoritized youth as we're building out their pathway to care. Also being very intentional about psychoeducation around those negative consequences and mandated reporting and CPS reports and suicide risk assessments and safety plans and whatever the case may be. I have found that even though it's hard, the more information that I share about what I have to do with my next steps, the more likely the youth is able to come back to me and say, like, okay, like, thank you for sharing that with me. They're still a little scared, but as long as the process looks very similar to what they were expecting, they are able to understand why I did what I did and come back and we could talk about it and process it. In times where I've seen those, reports done behind their back, or they don't know about it, or you minimized how severe it was going to be and it was really bad and the police showed up at my house and all these different things, the more that we're contributing to those aspects of mistrust. Our facilitators are pretty much the opposite of our barriers, and we don't know as much about what the facilitators are to help seeking because we focus a lot on the barriers. But facilitators, having a supportive social network increases the likelihood that you'll seek support. Positive experiences of mental health care, even if it's your friend or your mom or people around you say that they have these positive experiences with mental health care, that's more likely to increase the chances that they are able to get support for themselves. Cultural responsiveness, cultural support, digital mental health literacy, and then successful referrals from parents, teachers with follow-up and follow-through, not just a list of things and here you go, figure it out on your own. How can you help me navigate this really hard, complicated process so that way I'm actually able to start therapy next week or tomorrow or in a month? All of those are key facilitators for help seeking for minoritized youth. Digital technology specifically, we've talked about this a little bit. The youth in the second video mentioned it as well. Youth are using digital spaces as a first step for learning about symptoms and seeking support. Some of them are using credible websites. They know their .edus from their high school class. They know what a university website looks like. They are trying their best to be intentional about the information that they're getting online. Some of them, not quite. And so we kind of have to be able to meet youth where they are, but some of them are using social media, understanding that I use social media because I want to hear a shared story, or this person shares about their experience in a very real, tangible way that I can relate to. Or I use forums because everybody in the online forum is kind of talking about their mental health in a way that creates a safe space for me because I can't talk about it with anybody else in the offline world. And then digital technology also raises awareness and amplifies teens' voices around mental health. I would say mental health campaigns, Black Mental Health Matters, Children's Mental Health Matters, all of these things, even if we think that the youth are not paying attention to them, they are. Especially the ones that are very intentional about cultural messaging and making sure that we're intentional about even just having Black and brown faces on the pictures that we use for these campaigns and all of these different things so the youth can continue or to see themselves in these campaigns, to know that mental health treatment is for them as well. Supportive social networks, both online and offline, increase the chances of help seeking, normalize mental health and therapy. They create safe spaces. 9 times out of 10, if you need it, it'll encourage mental health and help seeking, especially if the person that you're talking to at least knows how to point you in the right direction. Similarly to supportive and safe online communities. And then extended family caring socialization. So not just our parents or our siblings, thinking about our cousins or our uncles or our aunts or any of those different people that can create that supportive social network. I'm the only mental health professional in my family. So if people have mental health questions within the bounds that I'm allowed to answer, I come to them. If I wasn't a mental health professional, that decreases the chances that people have someone to ask about a simple mental health question, because everybody else in my family doesn't quite know as much as I do. So those very supportive social networks are protective, and enhance help seeking as well. And then positive therapeutic factors. What can we do as licensed clinicians? What can we do in our schools? Positive therapeutic relationships. Continuously build and maintain trust. Be intentional about your trust. Be intentional about the psychoeducation that you provide. Don't just assume that people know why you're doing what you're doing, or that they don't even care about the procedures for why you're doing what you're doing. I tend to explain as much as I can so that way I can continue to build trust and genuine interest and care, and people can kind of meet me where I am. I can meet them where they are. We can provide these welcoming, ongoing services so they're more likely to come, they're more likely to stay, they're more likely to get the long-term impact that they need, and have a supportive therapeutic environment. And then rapport building in a very culturally specific way. And this starts by asking people's preferences. What do you like? What do you prefer? What are your coping resources? What skills do you have? What do you wish to continue to build? What do you want to get out of therapy? If you've done therapy before, what went well the last time you did therapy? What went wrong the last time you did therapy? All of those different ways of rapport building above and beyond what we think about like basic like games or fun activities or things like that. And then measuring your treatment effectiveness by really being intentional about selecting evidence-based practices that are tested and normed on minoritized youth and families. We know that they're evidence-based practices, but do we know that they're evidence-based practices for the populations that we're serving? So it's two different questions. And so you have to be mindful of those. Are you proactively monitoring for new evidence for minoritized youth and families? There's not a lot of research. And so you just kind of have to pay attention to it, when you can and in the ways that you are allowed to through presentations like this or research or trusted online sources. And then in the treatment, in the therapy room or in the treatment room, collecting comprehensive data to guide the selection of treatment, making sure you're assessing for the mental health problems correctly, as we talked about, and not just paying attention to the behavioral symptoms or the somatic symptoms, because if we start with the wrong problem, then we're not going to address it correctly either. And then involving the patients in problem and treatment psychoeducation and shared treatment planning and including their values and their beliefs and their preferences in those treatments as well. And you'll have access to these slides, but for people who like to have like scales or things to ask specifically because they don't know where to start, here's a list of scales that also assess treatment effectiveness as well. Okay. Our mental health continuum, and this was kind of like touched on the whole time that we were showing all of the barriers and facilitators, what the problems are, why the problems exist, and from the youth's voice themselves. I created this flow chart or diagram or figure kind of like as a way to begin to understand a strengths-based way to kind of go through this pathway. I have gotten some feedback from Black youth. They have had some input about the way that this pathway looks. But for the most part, they agree that a lot of these core components are really important. So, understanding what my mental health symptoms are, and if I have an increase in mental health symptoms and I can't cope with it on my own, then I, figure out where I need to go. But then I understand that people might have negative messaging about mental health, but I try my best to not let that get in the way of me getting help. I know where to and how to access mental health support that I trust. A lot of Black teens said that they actually say that this exclusively happens for them online, but I haven't changed that yet because I want to get some more input about whether that is actually true. And then I have people who encourage me to get help. At least one of these facilitators will increase the likelihood that they move on to the support selection phase. The more barriers that they have to those external or more formal services, the more likely that they're able to turn to self-help and tech supports. So, how can we point them in the direction of a support that is evidence-based, that is supportive, that is tested and normed on youth, specifically minoritized youth? How can we build up those social supports and community supports to um, provide mental health literacy in a way that is supportive and reduces stigma? And then if they do end up making it into our offices, how can we be mindful of our role in treatment effectiveness and decreasing mistrust in order to maintain their ability to continue to seek help in the future? As a reminder, these are our preferences. And so I do want to use the last few minutes to kind of go over what this looks like in the literature and what this looks like for me. So, integration of digital mental health resources. I have this poster up in my office. I edit it sometimes when those apps go away or the features kind of go away, but there's a combination of self-care apps, journaling apps, daily affirmations, coloring books, mood tracking, and then our 988 hotline, and all of those different things. Because I do, if someone comes into my office and says that they heavily rely on digital spaces and social media, instead of meeting them with judgment, I do try to meet them where they are and kind of learn more about their preferences for utilizing those spaces and kind of give them as many evidence-based practices online as I have access to. Knowing that that is a safe space for them, it helps to increase online support, it helps to increase online agency, it supports self-reliance in a very helpful, positive way. And then it can be a gateway to mental health, help seeking, and social support. There are also different agencies that are beginning to utilize digital outreach campaigns and interactive online care navigation platforms to provide online self-assessments that kind of triage you into your next steps. Do you just need a tip? Do you need a mental health information? Do you need to be connected to a crisis line? Do you need to be connected to our outpatient services? So kind of utilizing digital technology as a gateway to kind of like assess and triage. And then a list of mental health resources specifically for Black youth. And say if you run out of options or don't know where to go, they have like therapy for Black girls, therapy for Black men, Black Mental Wellness, Black Mental Health Alliance. And there's a lot of different websites that actually have spaces on there to connect youth and families to providers that look like them. Okay. Before we get into our one key takeaway, I do want to kind of highlight that the key takeaways today are that mental health help seeking is happening, just not in the traditional ways that we expect and that we are looking for it. Digital technology is often the first step in help seeking, supporting mental health literacy, connection, and reducing barriers. Mental health support must align with youth voice and youth choice. So, like getting as much information from the youth wherever you can, whether it's a day-to-day interaction or a research project or whatever, or a school campaign or whatever your role actually looks like, just making sure that you are listening and really intentionally getting the feedback from youth because they have really great ideas. And I feel like every time I talk about to them about these different specific things that we're thinking about and mental health, they have really good ways to actually address it in ways that I don't even understand. And I think that I'm a little bit closer to their age than I than they make me feel. But like really incorporating youth voice and choice. And then engagement meets youth where they are. It is strengths-based, it is culturally responsive, and it is trust enhancing. And just understanding that there are various ways in which we can begin to navigate through these barriers. But we have to be able to engage youth and their families in a way that is strengths-based and culturally responsive. Okay. Any questions for me? We have one more minute. And then here's my contact information for anybody that needs it. If you have any questions or follow up, I will be providing access to the slides as well as a few resources that I mentioned really briefly in the PowerPoint. Otherwise, thank you so much for being here today.
Thank you, Dr. Goodwin. Really, really good information. Very valuable. And we're so grateful to have had you here today to share that with us. Thanks to all of you for joining us today. You will receive an email with a link to the presentation and the recording, as well as a survey so that we continually improve these webinars and bring interesting topics to you. We'll meet again next month, Thursday, June 18th, when Rota will present the stages of change. It's still May, so we're still recognizing children's mental health. So if you haven't already, please consider joining the Children's Mental Health Matters campaign. You'll be joining almost 1,000 other advocates. For existing champions, visit our Champion Corner to get details about the campaign and upcoming events. As a note, the planned champion rally we have for next week, unfortunately, will be canceled, but we will be following up with information and all the ways that we're celebrating our champions this year. And we look forward to working with all of you, supporting families across the state of Maryland. If you have any questions, reach out to us by email at info@cmhm.mhamd.org. Thank you all again and enjoy the rest of your week. And thanks again, Dr. Goodwin.